I wanted to start with going back before Assam, maybe before you even started your professional journey. When was the very first time that you experienced failure? Very first time that you actually recognized that, oh, okay, this is a failure for me. And how did you? I mean, essentially, what I want to try and do is understand how did you recognize it? What was that formative thing that helped you to overcome it?
I didn't know it was failure, but then as a student, as a schoolboy, I was extremely introverted. I was afraid of my own shadow, and I would get bullied around in school. And you know who my defender was? My sister, who was 2 years younger to me. She would come and she would set all the bullies right, and I would and you know my father was in the Air Force. So the advantage of being an Air Force kid is every few years you get to reinvent yourself. So so you could be a new version of yourself. So by the time I was in class 11, I was fed up of myself. I hated the way I was, I had to change. And so my father fortunately got transferred from Banaras to Tamra. And so whole new system, whole new school. And so when I went there, I decided now enough is enough, I must change. And so it so happened that they allotted me a section that I didn't want to go to, because my father was posted ahead of school opening and I had made some friends in one of the other sections. And so when Ms. Bhagyalakshmi allotted me the section, I got the courage to tell her, no, I don't want this section, give me another. So they tried talking to me, no, you will make, I didn't listen. She said, okay, take it. And for the first time in my life, I learned that you could ask for something and actually get it. That left a very deep, I don't know what would have happened if she had said, no, buzz off. But she didn't. And then through that year, I made it a habit to put myself in positions where people would laugh at me and I would just brazen it. So we would go to lunch, I would go home. My home was about 10 minutes from school, so we had a half an hour lunch break. I had 10 minutes to go, 10 minutes to come, and 10 minutes to eat. So I would use a bicycle, and then my trousers, those days was a fashion to have long Amitabh Bachchan style, bell bottoms, So those would get caught in the cycling chain, and so I would tuck it inside my socks, and then I would leave. Initially, I would forget to pull the trousers, the flares out, and then the whole class would look at me and laugh, and I would look at them and laugh back again. And so I guess now looking back, that is probably the first time I recognized failing and organically said it right.
So you say courage and resilience came organically.
My father would be fed up of me. When I was younger, he would say, how can you be afraid of everything? And he's not used to fear. And his son is fearful about everything,
So how did you overcome that fear?
This was the first thing, I learned, it's okay to
be laughed at.
Yeah, it's okay.
Okay, and when you moved to Assam and you started the hospital, what were the initial setbacks that you felt? What were the initial pivots that you had?
So I trained in Chennai and worked in Chennai for many years. I worked with some of the most amazing physicians of those times. And so in Chennai we had a philosophy that healthcare has to be provided for everybody. It's not the doctor or the institution that is providing healthcare is not doing a favor to the sick person. And so we had a policy that anybody who needs, irrespective of their paying capacity, must be provided care. So when we went to Assam, my first thought was you provide low cost, no cost treatment, boarding logic, and everybody will complete treatment. And that is how we actually started. And as somebody said, we didn't do any audit of what was happening. We didn't look at the facts of what. I just assumed that it's all going well. And then somebody provided us a grant, and an organization in the US, the Indo-American Cancer Association, they provided us a grant to start a division for palliative care. And they gave us money to train a doctor and a nurse, and the subsequent year we had to make a presentation on the impact. For the first time, I realized that there's something called impact. And so we had to make a presentation in their annual meeting. And when we looked at data, we found that 30% of our patients came back for oral morphine. Morphine is a small tablet that is a key drug for pain relief in cancer. And cancer pain is a very common problem which needs to be addressed. So 30%, very poor figure. It means 70% are going home and not coming back for palliative care. They are dying unsupported. And so when we went to the meeting, we actually made a presentation where we said this is what is happening. But I also added a line saying that this is because they are all dying and they are not traveling from far off places. They are not coming back to collect morphine. But people that we are treating with intent to cure, we are giving them boarding, lodging, low cost treatment. They are all doing very well. Actually, I made this statement. And when I made this statement, I was wondering, is this right? So when we went back, we looked at our registry data again, and we found that, almost 60% of patients were not even coming back for a second visit to the hospital, let alone complete treatment, investigations and treatment. And of the remaining, only about half were completing treatment. That means all that we were doing was a washout, not helping anybody. And for the first time we realized, we were being prescriptive. We do this and everybody, we never looked at trying to find out what is it that the end user needs, that the sick man and their families need. And then, we were puzzled. For our minds, we thought we were doing everything. What more could you do? And then we realized that, so again we went back to the registry data. Amit said, almost 80% are daily wage earners. For the first time, even then, we didn't do a root cause analysis, we didn't we just assumed, they have daily wage earners, and so they're losing out on wages. Cancer treatment takes a long time. Drug costs are there, treatment costs are there, treatment lasts several months, many of them will die. And so if they have to lose wages, they often come back and say, no way, let this man or woman die. And so we took a decision, again a knee-jerk reaction. We said, they are daily wage earners, let's provide daily wages for them. And then, look at the fallacy. We said, we actually wrote seeking project grants to open a tailoring unit, opening a paper making. But imagine somebody who does not, these people have no skills. If they have to learn tailoring to work in a tailoring unit, 6 months are gone. And so we quickly tore up all that. We started providing unskilled employment in the kitchen, in the gardens, maintenance, pharmacy, stocking drug, things like that. And then we also took a policy decision that everybody who comes, we will make sure that they go out with a follow-up date. And then Abhijit, my colleague, wrote out a software which is still functioning. You open today's day, all the names appear, and as we see them, people's names disappear. Left behind are people who have not come. And then we get on the phone, call them. And so that year we actually deliberately went back and saw what was the impact of what we had done. And we found that about more than half of them, 55%, completed prescribed treatment. Not great, but then much better than 25%. But for a area like ours, if somebody in Mumbai were to say, Tata Memorial Hospital were to say that they treat 50-60% of patients that come there, it's a very good figure because most patients come from outstation. They will come for a diagnosis, for a stage and a treatment advice. They will take the prescription back home and get treated in a local hospital. For me, I'm the last stop. They're not taking my advice and going to somebody else. They're coming there for treatment or going home and dying. And so if I were to treat half of them, then it's not a great figure. So over the years, we put in place measure. Each time we find a problem, we saw, we were charging 100 rupees. valid for a month as consultation. Any number of doctors, any number of. But then imagine somebody who's poor, who's struggling to even pay for the travel every month. If they have to pay 100 rupees, they will disappear. They won't come back. Compliance will be poor. And so we revised. We said they will pay one-time charges, and then for a lifetime they will not be any. So like that we adopted several cost reduction strategies. And then at the same time, we also, and each time, each year we started looking at what is happening. And so very slowly the numbers improved. Then we also started visiting homes of people as part of the home care process. We also started visiting homes of people who were not coming to the hospital. And that improved compliance to a very large extent. But then more than the compliance improved was a good thing. But then, see, when we treat poor people, there is a lot of mistrust in the organization. We always feel that the sick man who is coming has money, he will spend on other things, but he will not spend on health care. So, every time, and I was surrounded by youngsters, and they would come and crib and say, oh, everybody is cheating you. Anybody who comes and cries, you write off. It's not. When we started visiting homes, it's a first-hand exposure to people, and we know that there is no money. Poverty is not imagined. It is not, really they don't have money. And very quickly, this home care, more than improving compliance, which it did, it actually brought the whole organization on the same page. Today, somebody comes to the hospital, we never ask them to prove their poverty. We just find out, accept what they say, and move on. Otherwise, we will spend a lot of energy and time on looking at what he can provide, he can give us, rather than what he needs, Yeah. And so, and then despite all of this, sometimes horrible things happen. So we did a big abdominal surgery on a man who's about 40-45 years, and he needed some medicine that was costing 3,000-4,000 rupees. And so when we told his wife after the surgery, she said, okay, aap de do, we will pay later. Okay, dawai de diya, discharge time comes. The report comes suggesting that he would benefit by some chemotherapy. So when we told the lady that her husband needs chemotherapy, she breaks down sobbing, discharge my husband. Doctor ko dekho, discharge. Nurse ko dekho, discharge. See, whoever discharge. All right, discharge. Debu is now our admin officer. He used to be the pharmacist those days. So he said, we have drugs that we can give her for free. I said, okay, shall I tell her? When Debu tells her, she falls at his feet crying because she didn't have 5,000 rupees. So she took her 7-year-old son to the village landlord and sold him for 2 years for 5,000 rupees. That day, that boy has called from somewhere. He does not know he's been pledged. So they make me fetch water from far off. My chest hurts. When will you come and pick me up? We had goosebumps. We were righteously angry. Oh, discharge, give her the money. Call the SP, call the MP. She would not touch the money. Whatever we said, she would. And then we realized later she has to go back to that village. And if she quarrels with the village headman or landlord or whoever, where will she go and stay? And so she wouldn't. He stayed, he took the chemotherapy, and we reasoned out with her. She took the money. The landlord also must have been a kind man. He released the child. Child came to see me later. But that's not the end of the story. 9 months later, this man develops multiple metastases and dies. This is not the first time this has happened. I'm sure it happens frequently. Sometimes we come to know of it, sometimes we don't know about it. And so these are all, they are failures of the system. They are also personal failures.
Sure.
We made it happen. I made it happen by talking without,
So to do what you do, right? You mentioned names of people that you work with. You mentioned young people. You mentioned assumptions. You mentioned the fact that every step that you did improved the numbers, the quality, the approach more. But in order to do what you do, in order to be, resilient, to continue to work, to continue to have hope, what are your learnings on building people and a team around you? Like the team that actually runs the hospital, the scale at which it runs, what are some of the learnings around that?
So that is my current angst. We're going through a time of intense soul searching. One of the things is, we have about our whole palliative care program is nurse driven. Our whole preventive oncology, many of our systems, chemotherapy is all nurse driven. And so they all grow, and it is a pleasure watching them grow. So we have a lot of community programs. We go into the community, because we want to promote health. We want to promote early detection. We want to reduce the incidence of advanced cancers. And see, just 1 minute digression.
Please, no.
Cancer, principal reasons are tobacco, areca nut, alcohol, dietary preferences and practices, inadequate physical activity, and some infections and inflammations. These are the 4 or 5 most relevant causes for cancer in India and many developing countries. So if you prevent these, in India, 60-70% of cancers can be prevented. Put cancer aside for a minute. If you look at heart attack, causes are tobacco, alcohol, dietary practices, exercise. You look at strokes, tobacco, alcohol, dietary exercise. If you look at peripheral vascular disease, if you look at diabetes, if you look at hypertension, many non-communicable diseases have the same set of causes. And so, if you prevent cancer, you also prevent all these other diseases. And you're actually promoting health in the community. And I just want to take this opportunity, if all of us in this room decide that we want to do this is all we have to do. We have to talk about these 4 or 5 things. Somewhere some impact will happen. And we would, in a small way, have done much. Anyway, coming back. So we go into the community, we try a model for detection, we train Asha. Asha will go into the community, do door-to-door physical examination. In another community, she will go door-to-door, create awareness, and promote health-seeking behaviors. So we were finishing this project. We finished the first project in Dholai, and then COVID struck. And so somewhere it petered out to a very low level of activity. Meanwhile, we started another project in Cachar, and last year we were completing the project. So at that time, one of the community nurses, she's not a formally trained nurse. She's a Dai who has been trained, who's good in communication, goes into the community. She's not a registered nurse. So in a stock taking meeting, she asks me, sir, we go into these communities, we carry out a project, and as part of that project, we are creating an expectation in the community. We identify people with cancer, we bring them into the hospital, we treat them, and so we built connections, we built bridges. And then your project is over, project funding dies up, you submit your report, dust your hands, and move on. Is this ethical? That was a blow on my face. Our ethics committee should have said, don't do it this way. But this girl, who's not a doctor, who's not a scientist, who's a nurse just doing what I'm telling her, go do this, that's what she does, and she has the thought to come and ask me, she has the courage to come and ask me. And so now, every project that we start, we are now also looking at how are we to sustain it when the funding is no longer there, when the active project is no longer there. So we're looking at different models. And so that is why, when somebody was speaking on food security in Africa, very taken up, because we look all over the world. See, there are only 2 ways in which any community is sustained. Either the government takes it up. To bring it into the government system is, as somebody mentioned, 10-15 year job. It will take a long time. The other is the community itself adopts it. So that is what is happening in Kerala, in the neighborhood networks for palliative care. Palliative care, responsibility for palliative care in the community
is picked up by the community. And in some communities, they actually have the resources to employ a doctor, have an ambulance, have a small clinic. And so we are now trying to see if we can replicate that model in Assam, but also piggyback ride health promotion on the back of palliative care. So in order for the community to take up something, they must see value in what they are doing. Right. Otherwise, so food security in some African countries works because, or water works because it is such a vital need. So the community will take responsibility for it. But health promotion is something nobody will bother. But then palliative care is something that they will appreciate, because everybody has, in the family will have, somebody will have a stroke, somebody, if nothing, they'll just grow old. And they will need support in their own family, in their own houses. So we are now looking at trying to see if we can create community ownership for palliative care. So we tried it in a small way. Our nurses did this also as part of a PEP program. So when we do home visits for palliative care, we said P, palliative care, E, early detection, P, prevention. So the whole village will gather to see what is happening. So once the palliative care activity is over, the ascites is drained of whatever is done, they gather all the onlookers, talk to them about cancer causes, because they are captive audience then. Sure. And then we administer a questionnaire, and then we promote health. So we're trying to see if the community can take ownership for. So what happens is, our nurses, our staff, they get empowered as part of health, providing health. They take ownership. It is their project now. It is not the hospital's project or the administrator's project. So coming back to your original question, what happens with the staff? So over the years, we, again, not formally, we didn't have a HR person, we didn't have somebody who will create values and all that. But then I think what has happened is, in the last 15, 16, 17 years, a lot of progress has been driven just on adrenaline. So we were passionate about it. More people joined, everybody. So we had nothing. So we had somebody, Abhijit joined us to create the IT infrastructure. Debu joined us for the pharmacy. Then he moved on to administration. So Shubhadra joined us. She created the whole preventive oncology program. So like that, we had people joining us, and each of them was actually co-creating something. Right. And so, because they were passionate about what they are doing, the whole thing has grown. And it has grown only because we didn't have any other motivating factor. But now what is so from a 23 member team, we are now nearly 480 members. And then we put up a satellite in Lakhipur, we put up a satellite in Barigram, in different areas. We now have 5 campuses. Last month, the government of Tripura gave us 15 acres of land, wanting us to replicate this model in North Tripura. So now we are having more people join, and as more people join, there are more questions amongst the staff. See, all these years, we didn't bother about designations. We didn't bother about growth trajectory. Sure. We didn't bother about...
what is my future in the organization?
Yeah, my future. We didn't bother about work-life balance. Sure. Work-life balance is... So we didn't, but then we have younger people join, and they're not wrong. Yeah. You understand? I think the questions that younger people are asking are all relevant. Sure. As older people, we are the barriers to... I think... don't you agree?
I agree. In fact, outside over coffee, I think someone was saying that, you never take a Sunday off. I think your point was that I never feel it's a Monday or Sunday, right? What you're doing is life, I think, in many ways. That's what the way you framed it was very different than what someone who's asking for a work-life balance would.
Yeah,
and neither is wrong. I don't think.
Thing is, now we are looking at how do we transfer values to the next generation, or to newer people who join us, who have not seen the initial struggle. My earlier reaction when all this started was that you know, the older people have philosophy because they have grown with the organization, and the younger people who have just passed out don't have values. This is what I used to think, you know. I used to think. Okay. But then I think I'm wrong.
Okay.
I think youngsters have stars in their eyes. They want to change the world. They
Agreed.
want to make good things happen.
100%, yeah.
It is we barriers. See what happens, you know, Debu joined as a 23-year-old bachelor. He grew, he got married. Like Debu, others also, they made babies. Babies have to go to school. They need a vehicle, they need a house, they need to take, these are not unjustified requirements,
sure.
you know. So some variation with values happens as they grow older. It is natural. But the biggest variation, change from values, see, all of us sat down and wrote our vision. You know, we want to be a hospital that wants to prevent all preventable cancers. We want to be a hospital that will give treatment for everybody. We want to be a hospital that will make sure nobody suffers in indignity and pain during dying. And we want to make sure, this is very important, that no family will be impoverished because of cancer care in the hospital. And for that we wrote our values. We said, you know, we believe in teamwork, we believe in compassion. Compassion is the most important value that we try to promote. We believe in science-based care, we believe in gratitude. We wrote our core values. But now how are we going to teach these values to others? So what happens is, one is, yes, you show by example. Every opportunity when there is a problem, you address it. Which core value does the problem alter? And so make a decision highlighting this. So this is fine. But then what happens is, as the organization grows, there are other people who join, or the older people are there. Some of them become very important. And these very important people sometimes will stray out of line. They will not show up for work. They will take various misdemeanors. And I will say that these people are very important, so let's not ruffle them. But when a youngster doesn't come on time, I pull up immediately. So they see this dichotomy. And so this bothers them.
Yeah.
We have a policy that every patient must be seen the same day because they come from far off, they spend time, money, lose wages. And so sometimes the OPDs will go on till 10 o'clock or 11 o'clock in the night. So when I start prioritizing patients over the well-being of the staff, it bothers them. You understand? So a series of activities like this that the leadership demonstrates that shows a lack of care for the staff, you know, disillusions them.
Right.
And I think that is the most important reason why values fade.
Yeah.
And then, you know, I always thought, you know, the organization, we 450 happy troopers. I used to think everybody is, And then we have created a group called Friends of Cachar. There are people from all over, like you, who help us in many ways. And so some of them are into HR and leadership training and all that. So 3 or 4 days ago, we had Partho and Uma come. They are basically into human resource training. And so they wanted to do a goal setting exercise. So they gathered all the leadership. I was not there. And started talking about goals of leadership. And then one of them said, why are you talking of these goals when we ourselves? And then the conversation went on, and a whole lot of reasons for unhappiness. One page full of, you know. So Partho asked one of the participants, why are you saying all this? Are you the spokesperson for all these people? So she said, no, I'm speaking for all of them. So Partho asked everybody, does everybody agree with this? And everybody said they agree with this. You understand? And so now I'm wondering, if we have so much of unhappiness in the organization, how will we make the sick person happy?
Sure.
So I told Partho, these are all people who've been with me for a very long time. You ask the next generation of people. Call the younger people and ask them the
They
same
will be
thing.
happy.
No. No. They came out and said the same things.
They're united on.
Yeah, and so now I am introspecting. Last 4 or 5 days have been and I'm introspecting. See, if the top, all of them feel, then it has nothing to do with the admin. It is directly me.
Yeah.
Because they all traveled the journey with me.
Yeah.
And they have not told me all of this, and they went and happily told all of this to some stranger who walked into the hospital. And so I'm now, I've gone to the extent, I was talking to Sita this morning, and I'm really introspecting as an individual, where have I gone wrong? So I'm asking, it felt foolish when I thought about it later, but I'm asking her, have I ruined your career? I don't feel like that, but when all of this comes around, then yesterday we were on the flight I boarded Kolkata. One of my colleagues called me and she wept nobody is respecting me, I ask for many things, it doesn't happen on time, and just, So yeah, now when I say it is funny, but it's also, for me right now, it's a very serious introspection as to how do we work with a growing organization, people from different, and how do we get all of them to focus on
What is actually needed.
Yeah.
Sure. No, thank you so much, Dr. Ravi. I do have a few questions, but I think given time, I'll just maybe focus on the final one, and definitely I think I would want to open up to audience, but Dr. Ravi is around, and I think they can definitely interact with you after this. You have gone on this mission of providing holistic healthcare, and I think you gave a lot of instances and examples around what would you advise people, what would you do differently, what are things where you feel you are failing, where you have failed. After all of that, improving the numbers, the metrics, really kind of ensuring that you're helping people live and survive and be able, right, in order to do things, in order to, add and contribute. What would you still say is something that you would do differently, you would want to do more of, you would rethink?
Yeah, thank you for that also, because that is another of our current obsessions. See, what we realize is we are treating a lot of people. Some of them become well, some of them don't become well, they die. Those who get cured, we are happy. We have a big cancer, we cut it off, we took a tissue from the leg or from the thigh or somewhere, put it there, put everything back. He had a pipe in the nose, pipe in the throat, we removed everything. We've sent him back one piece, he's able to swallow, he's able to speak, he's living at home, everybody is happy. A few months ago, I was telling this to somebody this morning, a few months ago, we looked at patients whom we have treated and now they are cured. More than 70-80% have not gone back to productive work. See, these are all poor people, and they are all, most of them are daily wage earners, fishing nets, agri labor, I have cured somebody physically, but they have gone back as a burden to their family. On one hand, the family, they're not going to complain that the man is alive. But we as physicians, we have created a burden. And if the breadwinner, after like the other man dies, the family is nowhere. So, and then the other thing when an adult mother or father falls ill, in Assam, often the first casualty is the child's education, especially the male child's education. Because these are daily wage earners, their earnings have stopped, somebody has to bring the money home. And so the children are employed at work. Even though education is free, uniform is free, books are free, everything is free, but they drop out. They have, yeah. And so what we now realize is when we focus on the sick person, it's actually a big environment about the sick. There is also livelihood to be considered. There is also education to be considered. And you cannot look at healthcare alone and say, oh, yeah, chale jao. We have to see what happens after the healthcare. What happens during the healthcare? We provide employment, ad hoc employment on campus. And we thought, that's a great activity. I'm very proud. I used to be at least very proud of that idea. Then some time ago, we audited how many people took us. So out of about 3,000 odd people who took employment, who were treated, not even 30 people took employment. And the truth is, many times when we tell them that we can give you employment, many of them don't want to work. Initial years, we used to get angry, righteously angry. I'm giving you treatment, I'm giving you food, and you're not willing to work for it. Arey, how can I take that point? I cannot thrust my thoughts on somebody else, no? And imagine they are taking care of a sick person. And how will they leave that person and come away? Or a sick child, how can that mother or father work when the child is getting chemotherapy upstairs? And so, livelihood is something we have to handle with great sensitivity. Everybody may not be ready for every kind of work. And some families may not want their women folk to work at all. And we have to work around that.
Right.
We cannot
focus on the needs, the strengths, the underlying
And
causes.
so, when we do healthcare, we have to look at healthcare important, but also we may not do it, but we have to collaborate with somebody who will do the employment, livelihood part. We have to focus with contact with somebody who will. Together, we must network to make sure all these points are covered.
Right. Thank you so much, Dr. Ravi. I think that's a
Thank
great
you.
note to round off on.